Hello everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar, The High BMI Mother, Challenges and Care Strategies Related to Patient Safety and the Obstetrical Nurse. And now I'd like to introduce you to Carol Elaine Brown, who is our moderator today. Elaine is currently a Nurse Program Development Specialist at the Association of Women's Health, Obstetric, and Neonatal Nursing for AWHONN in Washington, D.C. She is the manager of the clinical aspects of AWHONN's fetal heart monitoring program, and she is a nurse planner. Elaine's previous clinical experiences have included perinatal staff, administrative, and consultant positions in several acute care hospitals in South Carolina. Elaine, welcome, and I'm so glad to be working with you for this special session, and we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
Thank you very much, Emily. I appreciate that introduction, and we appreciate the opportunity to be here. Good morning and good afternoon to those of you who have registered for this webinar today. This program is provided in collaboration with the Association of Women's Health, Obstetrics, and Neonatal Nursing and Philips. We thank you for participating in the webinar. Our speaker today is Deborah Cruz, MSN, CRNP. Ms. Cruz is currently a perinatal nurse practitioner and clinical specialist for labor and delivery and high-risk obstetrics at the Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. She is a long-standing and active member of AWHONN and is currently the New Jersey section's Secretary-Treasurer. Debbie is widely published and has been awarded multiple recognitions over the course of her practice. She has been an instructor in the AWHONN Fetal Monitoring Program since its inception and has been involved with revisions of the courses and in the textbook Fetal Heart Monitoring Principles and Practices. She is a highly sought-after speaker and is presented at multiple conferences, including the AWHONN Annual Conference. She teaches about patient safety in obstetrics and fetal monitoring for high-risk patients. I'd like now to go to our disclosure slide. Debbie has disclosed no conflicts of interest or financial affiliations with any products that may be mentioned during the presentation today. Our next slide shows us information about how to obtain continuing education certificates. This activity has been approved for one contact hour. At the end of the webinar, you can obtain the continuing education credits. A URL will be provided at the conclusion of this webinar. You will need to register on the test site, complete the evaluation form, and upon successful submission, you will be able to print your certificate of completion. The accreditation statement is also included on this slide. The activity today is supported by an educational grant from Philips. And now I'd like to turn the presentation over to Debbie. Thank you for being here, Debbie.
Elaine, thank you, and thank you to Philips for the opportunity to begin a discussion on this important challenge to patient care. We will be discussing the following learning objectives. We will be reviewing the prevalence of high BMI in the United States and the childbearing populations, discuss obesity in pregnancy and labor and implications for fetal assessment through fetal monitoring, and we'll identify strategies to maximize maternal and fetal safety of the high BMI mother during intrapartum period, and also the implications to fetal monitoring. And I really feel that this subject is kind of near and dear to me, and I can really go back in my career, much earlier in my career, and I could remember when we didn't talk about BMI, but we talked about the weight of the patient. And I can remember coming in on and off shift and being assigned a patient that was 25 weeks gestation. And along with that, she was being evaluated for preterm labor. At the time, again, we didn't speak of obesity in terms of BMI. We spoke of her as being overweight or obese, and she was over 300 pounds. I had to stay at her bedside. I couldn't pick up her contractions by the toco, and I couldn't palpate anything, but I could tell she was in definite distress when I felt that she was having a contraction. I couldn't pick up a consistent tracing due to her habitus, and the bed was so small that it was really difficult to position her in an appropriate position. The providers were very conservative in doing exams, and the last exam she had, she was closed. But you know, she delivered that baby in bed. I was frustrated. I knew that she was contracting, and I had very little assurance of the well-being of that fetus. And then I thought too, well, what about the patient? What did she feel? You know, I'm sure she was scared. Here I am all over her belly, can't get the baby's hearts to stay in. But was she also embarrassed? You know, did she feel guilty? Was she ashamed, anger? Did she have fear? So that was then, and how do we talk about obesity now? So defined by Merriam-Webster, the definition of obesity is a condition characterized by excessive accumulation and storage of fat in the body, which affects not only appearance, but disease processes as well. And when we look at the World Health Organization and National Institutes of Health, we quantify weight, and you can see the definition here that is most commonly used for calculating BMI. The World Health Organization has also further classified BMI and nutritional status and divided it into 6 categories. So you can see the underweight as having a BMI of below 18.5, and then going through normal weight, BMI, pre-obesity, obesity 1, obesity 2, and then obesity class 3 of a BMI above 40. So nutritional status is really a continuum, and at one end of the bar we have malnutrition, and at the other end of the scale we have obesity. I quote the World Health Organization publication that stated, "Obesity is one of today's most blatantly visible, yet most neglected public health." And the World Health Organization actually termed this globesity to signify that this is a major public health problem worldwide. The prevalence has doubled over the past decades. It has increased in the pregnant population, and it presents multiple health issues. Currently, obesity is the second most important health problem after smoking. So that's worldwide. What about in the United States? I was really surprised that 2 weeks ago in U.S. News, there was a headline that read, "Obesity rates surpass 35% in a record 7 states." The article quoted a report published by a Trust for America's Health and the Robert Wood Johnson Foundation. And it stated that 7 states in America had obesity rates among adults at or above 35%. And this is a record number and is an increase from 5 states in 2016. And in addition, no state had a significant improvement in its obesity rate over the past year. So definitely, and we have seen it in a United States issue as well. Looking at the CDC, there are multiple sources that exemplify everything that we're talking about so far. And here is an overall trend in obesity in adults and youth in the United States from 2019 through 2015, 2016. And again, while youth, their rate is not as high percentage of obesity prevalence, you can see that both youth and adults have an upward trend. Here we're looking at the overall prevalence of obesity in the adult population, and really when you look at this, you see that, I'm moving my mouse over a little bit just to point out some things, but almost 40% total. Again, it breaks it up into gender and age, and so you can see over 20 to 39, 40 to 59, and 60. And the trends for women and men are essentially the same. But when you look at it in general, men have higher rates of overweight and women have higher rates of obesity. The highest rates of obesity are really among middle age more than younger adults. This is a breakdown further into gender and ethnic groups, and when you look at it, they're looking at non-Hispanic white, non-Hispanic black, non-Hispanic Asian, and Hispanic. The Asian rate is much lower. And when you look at this, you see that the non-Hispanic black and Hispanic have definitely the highest rates. And think back to and all the information that we have on mortality, morbidity and mortality in the maternal population. And it's all kind of reflecting that as well. Here we have the prevalence of obesity among youth aged 2 through 19. And again, it breaks it up into gender and race. And again, you can see that the non-Hispanic Asian has a much lower rate than particularly the non-Hispanic black and Hispanic populations. So, Haines survey is the National Health and Nutrition Examination Survey. And the 2012 report actually commented on women's health and made certain points that I wanted to emphasize. The first point was that, and I think we've seen this through some of the stats, is that 58.5% of adult women in the United States were overweight or obese. Just that number. Over half of us are. The number of obese women, pregnant women, continues to rise. Black and Mexican women demonstrated an increased prevalence. And obesity as well as severe malnutrition, so those extremes of our scale, were similar as far as the hormonal and metabolic patterns seen in physical or emotional stress, and that will play into the ability to maintain pregnancy, become pregnant. In 2017, the National Center for Health Statistics published Brief 288, and this summarized key findings from the National Health and Nutrition Examination Survey. And when I look at this, a number of these points we've discussed already, particularly bullets 1, 2, and 4, as far as the prevalence of obesity being really almost 40% in adults and over 18% in youth. Prevalence of obesity was higher in middle-aged adults than among the younger adults. And then also the ethnic issues in bullet point 4. Bullet point 3 identifies that the prevalence of obesity was higher among youth aged 6 through 11 years and adolescents aged 12 through 19 compared to children aged 2 through 5. And again, the significance of that is that look at who we're providing care to. And we're providing care to, well, I hate to think of the 6 to 11, but sometimes we do border on that. But definitely the 12 to 19 are part of our chat, even while the younger adults may be 35.7% as opposed to 42.8% of middle-aged adults. That's still a lot of people. Consequences of obesity in health. Okay, this is in general, and I think that, we can look at these and we know them. Obviously, mortality, high blood pressure, cholesterol, triglyceride, diabetes, stroke, coronary heart disease, gallbladder disease, joint issues, and we can go on. One of the big ones I get concerned about too is sleep apnea, breathing problems, chronic inflammation. It's all here, and all of these things are multiplying. And I don't think we can forget also the issue of mental illness that goes along with this, and clinical depression and anxiety and other mental disorders that go along with the consequences of obesity on health. So what is the impact of high BMI on pregnancy? I think first we have to look at what are years ago not really being too concerned about weight gain in pregnancy to, hey, you're no longer eating for 2. So how does BMI translate in pregnancy? Well, first we need to know what her pre-pregnancy baseline is. We know that there will be a weight gain during pregnancy, but what is reasonable? So the Institute of Medicine, along with the National Research Council Committee, came up with a basic guideline. And when you look at this chart, you can see that, again, we have our pre-pregnancy BMI broken down into underweight, normal weight, overweight, and obese, and then identified single gestation, twin gestation, and I amended it to also include ACOG's statement on the mean pounds per week, how that would average out. So you can see that, someone who is underweight with a BMI of less than 18.5 for a singleton gestation may gain anywhere from 28 to 40 pounds during pregnancy. We don't really have information on twin gestation on this group. And ACOG would say, okay, second and third trimester, that may be 1 to 1.3 pounds per week. But then, and when you look at the bottom of the table, you can see that the obese woman whose BMI is greater than 30 for a single gestation may gain 11 to 20 pounds total, twin gestation 25 to 42 pounds total, with a mean pound per week of 0.5 pounds, or anywhere from 0.4 to 0.6. So FIGO, and I hope I'm saying that right, is the International Federation of Gynecology and Obstetrics. And I found this of interest because it's the only organization that really brings together professional societies of obstetricians and gynecologists on a global basis. I looked at their website and I found multiple references to obesity and high BMI that I found quite interesting. The first was, and this was published August 2016 in Gynecology and Women's Health, identified over 4 in 10 U.S. women are now classified as obese. And the rates of obesity between men and women have been largely comparable in the past years. But females have now surged ahead to around 40% compared to 35% of males. The next point that I found that was kind of interesting, May 2015, published in Newborn Health. Obesity during pregnancy could lead to a range of health problems for both expectant mothers and their babies. And there was a multi-center systematic review, and the centers were actually in Ireland, Sweden, and the UK. And they recommended that women struggling with obesity should ideally look to lose weight before pregnancy. And this was really emphasized after recent data suggesting that the global rate of maternal epidemic proportions, reaching 31% among women aged 20 to 39 years old in the United States, while European average was 30 to 37%, so even higher than in the United States. The next that I found interesting was from March 2018, and this was published in Newborn Health, and it identified overeating while breastfeeding could lead to health issues for the child. And basically, again, talked about among the associated problems are an increased risk of becoming obese and early onset puberty. And the last one that I thought was interesting was published in April of 2016, again in Newborn Health. Infants who have a higher body mass index are more likely to grow up to be obese than babies who are deemed to be the normal range, according to that study. So it was interesting to see globally how much is actually out there. What are the risks of high BMI on pregnancy and delivery? I started looking at some of the maternal implications. Pregnancy loss. Well, it was interesting because when I looked at pregnancy loss, all the data was demonstrating that pregnancy loss is higher with women with a high BMI as opposed to a normal BMI. But some of the study data was conflicting. There are some studies, and one study I found from 2004, Lashin, demonstrated that there was an increased incidence of early pregnancy loss, but not necessarily late miscarriage. But another study in 2012 by Oddwire found an increased rate of late miscarriage. There was a systematic review in 2011 by Boots and Stevenson, And that study actually demonstrated an increased risk of miscarriage in spontaneous conceiving obese women versus normal weight women. And the rate increased with increasing obesity. So women who were actually underweight at a BMI of less than 18.5 had a 4.1% increased risk. Women that were normal weight, 18.5 BMI, had a 2.7% risk. BMIs of 25 to 20, almost 30 had 4.3, so we see an increase in overweight. And then a BMI of 30 to 34.9 had an increase of 3.7 increased rate. And those women with a BMI of greater than 34.9 had an 11.3% increased risk of miscarriage. So definitely with the higher BMI, there was a greater incidence of miscarriage. Some of the other issues that you see with risks, hypertensive disorders, cardiovascular disease, diabetes, thromboembolism. Another one that I think is very interesting is when we talk about obstructive sleep apnea and sleep disordered breathing. There are a lot of studies that have been done on non-pregnant women discussing the risk factors of sleep disordered breathing. But there's not a whole lot that's characterized in pregnancy. In general, in the general population, sleep disorder 2 to 25% of middle-aged adults, and it can even be higher than that, as high as 40% in obese adults, and actually 70 to 90% more in morbidly obese adults. So pre-pregnancy BMI, age, chronic hypertension are known risk factors and have been associated with sleep disordered breathing in early pregnancy. And there have been studies done on that by Facco and Pian in 2014. And the question that comes up often from these studies is, well, how do we assess this in the prenatal environment? Do providers ask patients, do you snore? In a study by Bourgellier et al., he found that less than 3% of practitioners actually asked patients about snoring. 32% of patients in the study reported they did snore, and less than 5% of those patients stated that they were asked prenatally. So this may be one opportunity for us to find out is length of labor. Obesity does appear to contribute to both prolonging labor and also a failure of medical induction. And one study by Pesner et al. In 2009 found that the median dose and duration of pre-delivery oxytocin was significantly greater among patients with higher BMIs. And one thing that they found was that, for example, a BMI greater than 41, the mean dose of PIT was 5 units, and the duration of pre-delivery oxytocin was 8.5 hours, as opposed to a normal BMI patient that would have a median dose of PIT of 2.6 units, so half the amount, and a pre-delivery duration of oxytocin of 6.5 hours. So half the amount of oxytocin and at least 2 hours less of pre-delivery oxytocin in the normal BMI patient. Even with spontaneous labor, high BMI women are less likely to progress as per a standard labor curve. And there is an association of maternal weight with C-section risk, labor risk, and cervical dilatation during labor induction. And as the weight of the mom increases, the rate of cervical dilation decreased and the induction to delivery interval lengthened. And this was from an article by Nathalapi et al., and it was published in OBGYN in 2004. Which I think emphasizes, again, some of the risks of labor for high BMI patients. One of the questions that always comes up is, why is labor dysfunctional? Again, it's largely unknown. I found it kind of interesting that I found that there are some studies that have been done when they do C-sections. They've actually removed some of the uterine myometrial tissue, and what they found was that that tissue demonstrated impaired contractility. There's also some suggestion that leptin, which is released by adipose tissue, may inhibit uterine contractions. So again, we really don't know, but these are two issues that we have found, or two explanations that are possible. Other risk factors or risks for high BMI pregnancy and delivery: C-section birth and failed TOLAC. When I think of C-section, I also think about, what kind of incision are they going to do? And a lot of this has to do with the physicians being able to adequately visualize the field and to be able to deliver the baby. So another issue that goes along with that are adhesions. How many of these women have had potentially bariatric surgery and consequently multiple adhesions to the area to make entry into the uterus more difficult? I think about the healing process and the difficulty of healing, particularly if they have those added issues of diabetes and other medical complications. I think about infection. If the pannus is it falls over the incision, keeping that incision clean and dry. And again, infection and the possibility of maybe even needing something like a wound vac. Antibiotic coverage. There are guidelines for antibiotic coverage, and guidelines have now come up to increase the amount depending on the BMI of your patient for cesarean birth. Pain relief and airway issues are really two big, kind of interrelated because a lot of it deals with anesthesia. But it's actually been reported historically that up to 75% of all anesthesia-related maternal deaths occurred among obese women. And the greatest issue was not being able to achieve an endotracheal, the difficulty of intubating these patients. Along with that, as far as pain relief and anesthesia or analgesia goes, the issue with failed epidurals, multiple attempts to put in an epidural and not being able to achieve the accurate location, and sometimes inadvertent dural punctures. I think one of the things that we need to consider is with these patients maybe having an anesthesia consult even prior to them coming into labor to really fully assess these patients. And whether they're laboring or they're a scheduled cesarean birth, that's a very important concept to understand as far as what their anesthesia risks may be. Also looking at your facility, do you have endoscopic intubation abilities if they do have difficulty in gaining an airway? Do they consider potentially early epidural placement, or what are the other potential options for pain relief for patients that are requesting some type of regional relief? The other thing to think about is if an emergency occurs, it's always going to take longer because, as we said, it could take longer if they're going to go with the spinal. It could even take longer moving that patient from her labor room to the operating room. So all of these become issues when you're talking about the high BMI patient. Hemorrhage is another major issue, and we need to be aware with these patients, number one, what is their starting hemoglobin? And if we believe that she is a hemorrhage risk, do we need to have a type and cross available on her? Do we need to have tranexamic acid available on the unit? Or where do we get it, or who administers it? Does she have a history of hemorrhage, and what is her risk assessment? Considering their length of labor can be longer, they have a higher incidence of infection, so is there a higher incidence of III or choreo? What is the fetal estimated fetal weight, or does she have is going to have concerns or problems with atony? So in preparation for delivery for this patient, and really every patient, we need to consider what potentially additional medications do we need to have available at delivery, and what interventions do we need to have. Do we have accessibility to some type of balloon, tamponade balloon, such as a Bacary, or OR availability, B-Lynch insertion, or a possible hysterectomy if needed. When we look at high BMI risks, we also need to consider fetal and neonatal implications. And one of the big ones is congenital anomalies. And we know that congenital anomalies affect approximately 3% of all live-born births. And that number is going to be higher in women with a high BMI. We know, and published in the ACOG bulletin, and it's number 156, there's an increased risk of neurotube defects, hydrocephaly, cardiovascular, orofacial, such as cleft lip and palate, anal rectal, atresia, limb reduction anomalies. But one of the big issues with this is that, particularly with women with high BMIs, such as class 3, a BMI of 40 or more, it's harder to detect these on ultrasound. So the detection is more difficult by at least 20%. And so sometimes they need to consider other modes that they can identify some of these anomalies, such as potentially a vaginal probe ultrasound, and there's been some discussion that maybe an MRI could be possible for further detection. Another alarming statistic is the risk of stillbirth is increased with a higher BMI, quoted as being almost 40% more than a non-obese patient. In a study by Yao et al., it was a retrospective cohort study of 2.8 million women, and it found that it's a 30 and 42 weeks gestation with an increase in BMI. The increase in BMI significantly contributed to stillbirth and increased with gestational age as studied. So what they did, they looked at certain intervals of gestational age. Between 30 and 33 weeks was one group, 34 to 36 weeks, 37 to 39 weeks, and 40 to 42 weeks. And then they looked at BMIs of being overweight, class 1, class 2, class 3, and then a BMI of over 50. And what they found was that women with a BMI of greater than 50 had a 5.7 greater risk of stillbirth at 39 weeks and a 13.6 incidence of stillbirth at 41 weeks, respectively, compared to normal BMI weight women. So definitely a concern, with increase of stillbirth related to high BMI, and higher BMIs even having a greater risk. Notation that Black obese women have an even greater risk of stillbirth compared to white obese women. And again, when you consider, when we go back and look at the statistics of ethnic groups, Hispanic, non-Black, just the rate of obesity in that population and the Hispanic population was much higher than in either the non-Hispanic white and definitely Asian. So I think that that definitely plays into that a lot as well. And you can see some of the other issues, fetal growth issues, macrosomia, but if there are placental issues involved with hypertension, you can also see the opposite end, component of the scale as far as intrauterine growth restriction. Traumatic delivery, birth trauma, think about shoulder dystocia. And, with that, it may not just be shoulder dystocia because of the pelvic diameters, but there can be obstruction just in the visualization and being able to, for the provider for the baby. We see that neonatal intensive care admissions, hypoglycemia, possibly related to hyperinsulinemia if the mother had not been well controlled during her pregnancy, and then definitely an increased risk or a problem with decreased APGAR scores. So when we look at the fetal oxygen pathway, where are we impacting oxygen flow to this newborn or to this fetus? Is it environmental? Is it the lungs? And I think about it, does our mom have a sleep apnea problem? Does she have chronic hypertension? Does she have diabetes? Are there placental issues or uterine perfusion issues going on with her? Does she have polyhydramnios and the cords being compressed a lot? Or does she have low fluid and you have cord compression that way? So think about the history of this mom, and then where can we identify what will happen in this oxygen pathway to delivering oxygen to this fetus. So I always think about patients, and I think about patients that we've had and some of the issues that we've had. And this is just one case scenario that I just want to go over because I think that it exemplifies some of the issues that we as nurses have when we're taking care of these patients. So this is a patient that I'm going to call her Cynthia. She's scheduled for induction. She's 25 and she has had previous children. She's a gravida 4, para 3. She's had 3 term deliveries in the past. And she is 39 and 3 weeks gestation. Her indication for induction is chronic hypertension. And on review of her chart and by history, her pregnancy is significant for, number 1, morbid obesity. Her current weight is 480 pounds, which calculated out with her height to a BMI of 75. She had a 25-pound weight gain during this pregnancy, so she was a little bit over, what she should have gained during the pregnancy. In her chart, I did discover that they graded the level of her pannus, considering potentially if a cesarean would be necessary. And she had a pannus grade 4 with edema and bilateral leg edema. Her skin was intact. What a grade 4, there's a pannus grading system, and basically what a grade 4 is, it meant that the pannus actually extended to her mid-knee. So there were concerns about edema and, obviously the size of the pannus. And also with the edema, sometimes that can create more space so that when you're trying to obtain fetal hearts by ultrasound, there's more space to go for the sound waves to go through, and it can create more of a problem. She has a history of chronic hypertension, and that started actually early in pregnancy, so probably less than 20 weeks, and she is not currently on any medications for that. She has a history of depression, but she's not on any medications. She has a history of an atrial flutter, and she also has a family history of that, but she was a no-show for her cardiac consult. She has a history of sleep apnea, but she is not utilizing any interventions at this point, such as a BiPAP machine. She was a no-show for her anesthesia consult. She was a no-show for her dietary consult. She did have early glucola testing, and that was normal. And she does have a proven pelvis of a 10-pound, 9-ounce baby through a spontaneous vaginal delivery. She does have a history of mild asthma and exertion, and again, she is not taking any medications right now for her asthma. She, when she is admitted, her cervix is 250 and -2, and 2 weeks ago she had an ultrasound done and the baby was about 8 pounds, 3 ounces. Anesthesia interviewed the patient on admission. She stated that she had an epidural in the past, but it took 3 attempts to get the epidural in, and it really was not successful. So anesthesia noted that she had a short, stocky neck and poor visualization and class 4 airway. So they were very concerned about how well we would do with her airway if she required intubation. This is her tracing on the labor floor. This is with holding it in. And so when you're looking at this, what is the status of the baby? We have a lot of fallout. There is some concern about the fallout and that you just don't have a full picture. You know, if it kind of fill in the gaps, and it looks like she's accelerating and it looks like it would be a good tracing. But really, how can we induce someone with this lag in the tracing? So we ended up, before we delivered her, even started her induction, we insisted that we have an interdisciplinary meeting because we felt that we needed to look at the how we were going to induce her, and we decided we would use a cook because her cervix needed some cervical ripening, and so that would be a mechanical mechanism, and we could auscultate hearts with her or do intermittent monitoring during that time. Anesthesia emphasized the point that they wanted very clear communication with this, the updates on this patient. If there were any projected changes, they wanted to know immediately because they knew that it would take more time with her than it would a patient of a normal BMI. It was decided that once the Foley catheter balloon came out, the cook, that we would artificially rupture membranes, internalize, and then put in a scalp electrode and an intrauterine pressure catheter. We also considered, and staff needed to think about, okay, what is the weight limit of our labor beds? What is the weight limit of our OR table? And we found that the labor beds would hold 550 pounds and the OR table would hold 650. And we considered also the safety of our staff because definitely moving this patient did require, I call it like a hovercraft that is a blow-up mattress that really kind of makes it easier to move the patient. And also looking at additional support for a vaginal delivery that we, you know, particularly in supporting that patient, considering there may be a shoulder dystocia, so having ample people in the room during second stage or at the end of second stage. As we monitored this patient, this is 8 o'clock in the morning, she already had her cervical ripening device in for greater than 12 hours. And we continued actually to keep it in a little bit longer just to provide that early cervical ripening process. At 2 o'clock in the afternoon, the catheter did come out. She was artificially ruptured for clear fluid, and a scalp electrode and an intrauterine pressure catheter were placed. She's now 5 centimeters, 50% -2, and oxytocin was started. So again, with a fetal scalp electrode, definitely your perspective of the baby and oxygenation is you know, category 1 essentially. At 8:30, she is now 80 and -1. She's on 12 milliunits per minute of oxytocin, and she has a category 2 tracing, but very comfortable that this baby is accelerating and, you know, has good oxygen transfer. 10:56 p.m. she continues to be 80 and -1, so this is a little over 2 hours later. Her oxytocin is now up to 20 milliunits. And again, category 1 tracing at this point, the baby is demonstrating oxygenation and transport of oxygen. I think the one thing I want to say, we have wonderful pickup on this baby and it looks great, but she has had 4 scalp electrodes placed. So, you know, with vaginal exams and different things like that, they fall out, and they ended up replacing them because they could not get a good external mode of monitoring tracing. A little after midnight, she's now complete, she's pushing, and the only thing I want to say here is she has an intrauterine pressure catheter in. Look at her resting tone. Yes, it's elevated. Yes, she's on oxytocin, but I think that when you look at this, you also need to consider that due to her habitus, how is that potentially impacting resting tone? So, you know, I know that we don't like to see higher resting tones, and I think that that is always a concerning thing. But looking at the overall picture, how, if you can palpate her uterus and uterine relaxation, as well as the status of the fetus, they're all important components to consider. This is 40 or 41 minutes later. Again, she's had multiple scalp electrodes placed. She now has an anterior lip, and the bed is prepped, and she delivers, and she has a spontaneous vaginal delivery, and she does very well. She has a vigorous male baby. She had no anesthesia. It was direct OP. Apgars are 8-9, and you can see that she had a minimal blood loss. So her delivery actually went extremely well, and we were, you know, very pleased that we did not have to do any of the other things that we had planned as far as, well, if we need to go to the OR and different things like that. So it was a very positive outcome for her. And again, I think that we need to look at considering the care of this woman in labor, and the mode of monitoring is key in order to assess the status of this baby. We need to consider what her history is, the gestational age, any medical or history components that play along with that, and what is our ability to monitor that patient with the modes that we have suggested. When we look at monitoring, we look at multiple modes that we can monitor. And when we're looking at fetal heart rate versus uterine activity, with fetal heart rate, we can definitely auscultate. We can intermittently monitor with a either auscultation or with a electronic fetal monitor. We can use the conventional monitor. We can use a scalp electrode. And now there are external wireless devices, abdominal fetal monitoring, that actually picks up like an electrocardiogram of the baby. And on the uterine activity side, again, you can palpate. You can use the TOCO, intrauterine pressure catheter, IUPC, and again, there is the option of electrohysterography, which is essentially electrodes that measure the electrical currents or activity of the changes in the uterine pattern. And those mechanisms are now have been approved FDA, or at least one of them has been approved FDA in the United States. We have to remember when we consider how we're monitoring patients, again, what are the recommendations of our national organizations, A1 and ACOG, and again, I won't spend time on it. These are published on our websites, but how often that the evaluation and interpretation needs to mean for auscultation that every 15 to 30 minutes in latent labor you have to document, and it does mean that you do need to evaluate. And the same with using an electronic fetal monitor. And here you can see low risk without oxytocin, or then the second category is with oxytocin or with risk factors. So what are our options, and what are the best options? And I wanted to just very briefly go through 3 studies that demonstrated an impact of BMI on fetal monitoring. One was the ability to maintain a monitor tracing, the second was on contraction monitoring, and the third study deals more with combined fetal heart rate and contraction monitoring with high BMI patients. So, you know, we've all experienced issues when a fetus may be unmonitored for periods of time when we're using an external mode of monitoring, fetal monitoring, and it presents difficulty in maintaining a consistent tracing, and therefore gaps in fully understanding the fetal status. Does BMI present a disparity in monitoring ability? So this is, and what his purpose was to assess the impact of maternal obesity and the time of non-continuous tracing on an external monitor. And he looked at women that were being induced greater than or equal to 37 weeks gestation with a Bishop score less than 5. And he broke them up into 3 groups. He had 337 patients. Group 1 had BMIs less than 30. Group 2 had BMIs between 30 and 40. And Group 3 had BMIs greater than 40. And what he found, the mean percentage of unmonitored on EFM, Group 1 was unmonitored approximately 5% of the time, so the less than 30 BMI. Group 2, between 30 and 40 BMI, was unmonitored 7% of the time, but Group 3 was unmonitored 11% of the time, and that was the higher BMI woman. So again, we see the challenge that this sometimes can present. So another study is a study by Velamix, published in 2018 on the impact of high BMI on uterine monitoring. And do we have better options for the delivery of safer patient monitoring of contractions? So the purpose was to evaluate the influence of maternal obesity on the performance of the external TOCO, and then also looking at electrohysterography. And excuse me, they took a 2-hour period during labor on these patients. And they used the intrauterine pressure catheter, or the IUPC, as the gold standard. And then they also put a TOCO and the EHG, or the electrohysterography, on that patient. And so they divided the patients into 3 groups: non-obese, obese BMI between 30 and 40, and then morbidly obese with a BMI greater than 40. And what they found was that the sensitivity of the TOCO, first of all, was only 62 to 74%, and it further decreased with maternal obesity. And the EHG, or the hysterography component, appears not to be influenced by obesity and did not significantly differ between any of the 3 groups. So the less than 30 BMI, 30 to 40 BMI, and then greater than 40 BMI. They found that the positive predictive value of the TOCO was significantly reduced with obesity, with a 10.3% reduction from the non-obese patient and a 21.3% reduction from non-obese to a morbidly obese. So that's pretty significant. So definitely what this study found was that there were issues, with the sensitivity of a TOCO versus the EHG, and the EHG definitely demonstrated a better sensitivity. The last study I just want to briefly mention is one that looked at both fetal heart rate and contraction monitoring, and looked at the external modes of monitoring that we can use for both, as opposed to the internal modes of fetal scalp electrode, IUPC, as the gold standard. So really, this is a study by Cohen, published in 2014, and the objective was to evaluate the performance of the external electronic fetal heart rate and uterine contraction monitoring according to maternal body mass. And what they found was that when they looked at the overall success rate of the fetal abdominal electrocardiogram versus the ultrasound rate, they were actually fairly similar. However, when they looked at the patients that had a high BMI, and by high BMI they're talking about greater than 40 kilograms per meter squared, the success rate of the ultrasound was only like 66 versus 83%. So definitely with a higher BMI, the accuracy of the ultrasound mode of monitoring did fall off, whereas the ECG did very well. Interesting, which is a little bit different than the other study, they found that with both the external contraction modes, so the TOCO as well as the electrohysterography, that they were really, both methods were unaffected by maternal size. So in other words, there was no observed significant deterioration of any performance measures according to maternal BMI. Definitely a little bit different than what we found in the other study. So again, I think that we have to look at this information and realize that yes, the technology is out there. How we're using it, we need more information on. Definitely, when we look at barriers to care or we look at opportunities, there is still a large opportunity to investigate the modes of monitoring for high BMI patients and to be able to provide AFEG and the EHG device for term patients. So definitely studies that are done on preterm would be wonderful, and we be very helpful in our practice. Knowledgeable that the pregnant woman with a higher BMI has a greater risk of morbidity and oxygen transport issues to the fetus. We need to increase the vigilance of monitoring in this patient population. In summary, care is complex. We see that each patient is unique and we have to look at what their needs are. There's an ongoing assessment of not only the patient, but also do we have everything on our unit that we need to be able to provide the care? And we need to consider the physical as well as the psychosocial needs of this patient. Most important, we need to be able to speak up if there are issues and make them known to all providers. I am going to turn this over now to Elaine.
Debbie, thank you so much for this very pertinent information this afternoon. I know that all of us as clinicians will be able to apply this as we provide our patient care. Debbie, during your presentation, we've received multiple questions from our viewers. Nettie sent a question asking about the relationship of overeating while breastfeeding and the increased incidence of obesity in children. Could you talk a little bit about that for us?
Yes, I thought that was a very interesting concept because typically what we understand from the literature and the research is that formula feeding we know can cause an increase in obesity in children. However, there have been studies that have identified that moms who are breastfeeding, who do not eat a moderate and healthy diet, can have increased risks of various health problems with their offspring and children, and some of those can be obesity and diabetes. There was actually a study done by Wong, who, now again, this wasn't on humans, this was on mice, but what they found was that mice who were fed a diet that was maybe lacking in certain nutritional aspects, their offspring did have early puberty and glucose intolerance and insulin insensitivity. So these are issues that need to be further evaluated as we move along.
Thanks, Debbie. And another question, this came in from Angeline. Are the risks of high BMI that you listed on several of the slides, are those associative risk or are those causative?
Okay, that is, again, a great question because I think that when you look at this and you look at the risks of high BMI, it's really very complex, and there are a lot of complex interactions that are going along with that. Definitely, you know, some of these things, for example, diabetes, insulin intolerance with high BMI. Well, that makes sense that they're linked together and it would be, you know, maybe a causative mechanism. There's some components when you think about genetics. Can genetics be part of this? There's been some literature, and it's in the there will be a link that you can see for the CDC that identified, well, a lot of the genetic things would take too long to cause such a large epidemic like we have now. But it's believed that in combination with the interactions of a lot of the genetic issues along with environmental factors, and a lot of the environmental factors, maybe not moving around so much, lack of exercise, you know, different things like that, that multifactorial, are adding on to a lot of the issues that we are seeing with these patients. So it's complex and it can potentially be both.
Okay. Debbie, thanks for that answer. Another viewer has asked the question, is it recommended for all high BMI moms to have sleep studies during and or after their pregnancies?
I think a really important component of that is that maybe they don't need the actual sleep study, but they need to be evaluated to see if they have some type of sleep disorder. So NCBI actually has an algorithm that evaluates for obstructive sleep disorders. And out of that assessment or algorithm, it identifies, number one, who are the high-risk populations. Is that high-risk population, if that person is in that high-risk population, are they symptomatic? And I think that these are the questions as providers that we need to ask. For example, yes, if they're obese, do they snore? Do they have some type of retrogasthic, the jaw's recessed? Do they have daytime sleepiness, different issues like that, and are they hypertensive? There are some of the basic questions that are asked in this screening tool. And then if they meet that evaluation, then definitely they should have some type of sleep study done. And sleep studies can be done whether they're pregnant or not pregnant. If they have the issue, they should be evaluated.
Thanks, Debbie. More than one person asked questions about the dosing of oxytocin for high BMI moms for their labor induction or augmentation. Debbie, should there be changes in the oxytocin dosing for these high BMI moms?
I think that the one thing that we do know about high BMI moms is that there is a difference in their ability to contract, and that we do know that the myometrium has decreased contractile function more than a normal weight woman. But given that information, I'd be extremely concerned to move away from a standard of care that is established for a very high dose and high risk medication, oxytocin, and to go ahead and just increase the amount, because we know that there is some type of relationship between their maybe ineffectiveness with contractility. I think that these patients, we also know, can have more problems in picking up contractions, and we know that these patients can have babies that have a higher incidence of ICN and lower APGAR scores. So we need to be very careful about how we administer this medication and not just move forward and increase it faster or higher because we think that they're not going to progress as fast. We know they will not progress as fast in labor.
Thanks, Debbie. Nancy and Deb, two separate viewers today, submitted questions related to management of the second stage, and they also pointed out about management of pushing. Does that high BMI patient have specific needs related to second stage, and will that impact pushing?
Well, we do know just in general with labor that their labor will be longer, although second stage really has not been impacted as far as timing. But I think that the one thing that we need to think about is when we look at oxygen transport and look at the positions that we use in pushing, and it's for any patient, but then think of it as, gee, this high BMI patient, what is the weight of, if she's in a semi-sitting position or just a low Fowler's position and she's trying to push, what is the weight of the her pannus on her vessels, and how are we impacting oxygenation to the uteroplacental bed. So we need to look at, are there different positions? Can she be comfortable in more of a side-lying position? Do we maybe have her push every other contraction? And again, with stipulation that we need to be looking at how well this fetus is doing through second stage. Second stage is just a critical component of labor, and in particular for these patients, that we know that that fetus is being oxygenated well.
And Debbie, you brought up a good point. We all know that second stage, especially the active pushing part of second stage labor, is when there are the most instances of signal ambiguity. And it's so important that we keep a finger on the pulse of that fetal heart rate and the uterine activity. So I'm glad that they asked that question and you provided those answers for us.
I think that the other piece too that I think is so important is that this is where nurses need to speak up. And we see it all the time that we think, okay, maybe 4 more contractions and she's going to deliver. So, okay, maybe I don't have the hearts in the whole time, but I have a good inkling of what's going on. That's not good enough. And we need to be the gatekeeper, and we need to be the one saying, hey, I don't have a good tracing on this baby. I need to have a scalp electrode until she delivers. And we need to be the voice that's heard, to assure that that we are appropriately monitoring these patients.
Thanks, Debbie. Christy sent in a question. She's asking, if the woman is admitted and she is known to have sleep apnea, should she have a BiPAP machine available while she's in labor?
Definitely, if she has a sleep apnea machine, it means that she needs a sleep apnea machine. And so I would definitely have it available. And if, again, you need to look at institution policy to see, can they bring something in from home, or is this something that the institution would provide for the patient? But definitely, and then going into her postpartum, when she's in the hospital and she is sleeping, she should have it for her normal care.
Great. Debbie, I'm glad you mentioned the postpartum, because another person asked about barriers or complications that you might see during the postpartum period.
And I think that we've talked a lot about the intrapartum period. We've talked a lot about the issues with the uterus maybe not contracting as well. A lot of this can carry through to postpartum as well, and the incidence of potentially postpartum hemorrhage. They have women with a higher BMI have a higher incidence of developing choreo or endometritis. The other issues that I think about are, will they have problems with breastfeeding? There's some literature out there that shows that there's a lower prolactin response to suckling, and that kind of makes me think about, is that kind of relating to the endogenous oxytocin issue too? I'm not really sure, but it just kind of made me think about that. Their babies have a higher incidence of being an ICN, have a higher incidence of whether hypoglycemia or maybe it's hyperinsulinemia leading to hypoglycemia. So yes, these women do have a much higher risk postpartum course, higher risk of DVT. So getting patients up and having them move, which can be very difficult when they are particularly a post-op cesarean birth patient. They're extremely uncomfortable, and so making sure that their pain level is recognized, that we address that, but also address the issues of movement and VTE prophylaxis, wearing the stockings and different things like that. Many of these patients will be ordered Lovenox or heparin during their postpartum inpatient stay because of the higher risk of DVT.
Thanks, Debbie. I think it's important that we recognize the implications of these moms when they get to the mother, baby, or postpartum units. Debbie, another viewer, Jay, asked if there are any specific recommendations related to pregnancy and mothers who are post-bariatric surgery.
There are recommendations, and I would particularly refer people to, there is an ACOG bulletin number 105 on bariatric surgery and pregnancy. It was actually first written in 2009, but it was reaffirmed in 2017. And it really has a wealth of information about bariatric surgery and pregnancy.
Thanks, Debbie. And while you're mentioning ACOG, don't they have some type of toolkit
Yeah,
document that's available?
yes, they do. They have a toolkit on, I think it's called ACOG Toolkits for Healthcare Providers, and it's an obesity web resource summary that is available.
Great. That is great that we can call out our other colleague professionals and note that they have references and resources that will be helpful to the clinicians caring for these moms.
And I think that one of the things in particular, they also have a practice bulletin about high BMI or obesity and pregnancy. And I found it very helpful because it does address what type of equipment that you need to consider having and your unit should have, and the preparation that needs to occur.
Thanks, Debbie. Somebody else mentioned something, and I think all of us as clinicians have experienced this, the struggle to get an accurate blood pressure. What can we do? What devices can we use? What assistance or what help can you give us to guide us in that direction, Debbie?
Blood pressures can be very difficult on this population because it seems that the sleeves that we have or the cuffs that we have, you need to have one that is wide enough to fit the upper arm, but then it won't wrap or it comes undone, and it can be, frustrating. And we also know that it's not accurate for those patients. It's interesting because some of the literature that is out there now, and this is the British Medical Journal actually published an article in 2016, and it did say that really if you can't get a good fitting cuff on the arm, that probably the next best would be a wrist blood pressure. As opposed to some of the other mechanisms of finger or forearm.
Thanks, Debbie. Well, it looks like we're out of time. We do appreciate the attendees and the questions that individuals submitted for our speaker today. Debbie, is there going to be a reference list available?
Yes, there will be a reference list available for the listeners.
Thank you so much. And now I'll turn it back over to Emily to close this out.
I'd like to thank you very much for your time, both Deborah and as well to you, Elaine, for being our moderator today. It's been a pleasure working with you both. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.